Welcome, everyone, and thank you for joining us today. My name is Maria, and I'll be your host today. Today, we have a very special guest, Dr. Mozow Zuidema. Dr. Zuidema is board certified in internal medicine, cardiovascular disease, nuclear cardiology, and adult comprehensive echocardiology. Dr. Zuidema is a general cardiologist with expertise in cardiac imaging, as well as valvular and structural heart disease, heart failure, sports cardiology, and cardiac arrhythmia. Dr. Zuidema, welcome. Thank you for joining us today.
Thanks for having me.
Thank you. Dr. Zuidema, would you give us a kind of just a brief overview of the kind of patients you might see, or maybe what your day-to-day looks like, or what you might have studied? Let us know a little bit about what it is that you do.
Sure. I'm a general cardiologist, which means I see all kinds of cardiology patients. There are different kinds of cardiologists. Some of them specialize in implanting stents or interventional procedures. The interventions that I'm involved in include implanting certain kinds of valves through catheter techniques as opposed to opening the chest. And that's due to my specialty and interest in structural heart disease. So every day I see patients in clinic. We take turns being on call and seeing all the patients that come through the hospital with any kind of cardiac problem. When needed, I consult with my partners who do the stent procedures and otherwise with cardiac surgeons. And sometimes I'm involved in those surgeries as well to image the heart during the surgery with something called a transesophageal echocardiogram. We do treatment of abnormal heart rhythms, arrhythmias, with things like cardioversion, which essentially is a shock to the heart to get it to stop for a split second and come back to normal rhythm. We use medicines to keep people in normal rhythm or for prevention, longevity, like we're going to talk today, cholesterol, and treatment of heart disease. And heart disease is a broad term used to describe many problems with the heart. So as a general cardiologist, I take care of all of those. My training involved not only medical school, but I have a PhD in pharmacology. So my pharmacology research interest was studying models of lack of blood flow to the heart muscle or the gut called ischemia, that's lack of blood flow, and then looking at preconditioning models, meaning what can you do before that occurs to help prevent from the effects of that. So I studied it in mice and rats and in cells, and that was my research interest, and obtained an MD and a PhD from the University of Missouri in my training time. And then I've been in practice for about, let me think how many years, a little over 10 years now. So yep, here all in Columbia, Missouri.
Perfect. Thank you so much for that. So very hands-on, very close to the issue of heart disease. Today we are wanting to talk about a little bit about the book Outlive and one of the four horsemen, as he calls it, which is heart disease. So he, he talks about the diseases and the different issues that cause death in the United States, and then kind of goes into what can we do about it. So while genetics play a huge part, it seems, that doesn't mean that all hope is lost for the rest of us who might not have fantastic genes. So we're going to talk a little bit today about a variety of things that affect heart disease. All right. So we'll start off with one that most people might have heard about or be familiar with, and that is different diets. So the book talks about potentially using intermittent fasting and ketogenic diets as a strategy. From your perspective, from a cardiovascular health perspective, what are the potential benefits or the potential risks of doing some of these diets?
Right. I think out of those two diets, the one that makes the most sense is something like intermittent fasting. And essentially what that means is that you're eating for less hours of the day than you're fasting. And the typical model is something like a 16 and 8, which means for 16 hours of the day, you're not consuming anything with calories. You can drink water or have black coffee, but you're supposed to not have any calories. And then for 8 hours of the day, that's when you kind of compartmentalize when you do have calories. And simply by compartmentalizing the number of hours of the day that you have calories or sugar in your system, then your pancreas, which secretes insulin to soak up the sugar, will work better, and you will be less insulin resistant and therefore more insulin sensitive. And it's that technique over a period of time that can help not only with weight loss goals, but also with the other complications that can occur from insulin resistance. And Peter Attia brings data to show us in the book that insulin resistance is not only linked to obesity, but also to cancer risk and even cognitive decline and cardiovascular disease. So that's why intermittent fasting can be helpful. And if you even look at other books in the field, there's a very popular book called The Obesity Code. And that book gives us data over time why in the 1970s we were quite thin and ate butter and real sugar and all the meats and normal foods, whereas now we're exercising more, but in general we're heavier and have more insulin resistance. And part of that is because we started to eat multiple small meals throughout the day as soon as we wake up and right before bed, and that's led to insulin resistance. So if we work on intermittent fasting, that can be quite helpful. For the ketogenic diet, although it can be helpful for many patients, the basic premise is that if you consume mostly more fat in your diet and less carbohydrates, that your body will learn to burn fat instead of carbohydrates as a fuel source. The problem with that, from a cardiologist standpoint especially, is that if you consume too much fat, then that can become atherogenic. And so when my patients ask how they can proceed with a ketogenic diet but still have cardiovascular health and benefit, I advise them to try to limit the amount of animal fat. So it's important to know that you can get fat from vegetables, and that those vegetable fats can be very healthy and not as atherogenic as the animal fats. And that's one way that you can proceed with a ketogenic diet. The ketogenic diet can also help improve insulin sensitivity and decrease insulin resistance as well. There are many patients who may even come off of insulin, diabetic patients who can come off of insulin if they follow a ketogenic diet quite strictly, but not just partially. So everything just kind of needs some education through your practitioner to help you follow those diets in as healthy way as possible. But both can be quite helpful.
Yeah, that's amazing that you've been able to see that
for sure
kind of shift from people doing this for a period of time and being able to have their bodies work better than they were before. Would you suggest that these are things that are done for a small period of time, or in your experience, if you're ever recommending a patient do either of these diets or these approaches, is it something that is for the long term, or is it for a generally small period of time?
Right. Well, definitely for intermittent fasting, I consider that more of a lifestyle change. When we talk about diets and the benefits, really the benefits are longer lasting if you make a lifestyle change. So if there are benefits to eating certain foods or not eating other foods and to eating in a certain way, I think that those benefits are best if you make a lifestyle change and not a temporary measure. So intermittent fasting is something that I think is quite easy to initiate and continue throughout the rest of your life. The ketogenic diet is a little bit harder, but I think the basic premise of that is to try to decrease, for me, one way to promote using the ketogenic diet principles and making a lifestyle change is to simply work on decreasing the number of carbohydrates and simple sugars in your diet, not necessarily increasing all fats, but try to decrease the amount of animal fat and increase how many vegetables you have. And then that's kind of an easy lifestyle modification for the long term, because that's what we're going for.
Perfect. Thank you. So another potential lifestyle change that I think we all know or we've heard about is exercise. So we all know how good that can be, and it, makes an effect on all of the four horsemen, just like diet does as well, where it's not only affecting heart disease, but potentially making an impact on type 2 diabetes. So that's the positive side of making the lifestyle changes, is that not each, they're all related. And I think that's a point that Peter Attia tries to make, is that they're more connected than maybe we know, and definitely more connected than how we treat them. So for exercise, what would your recommendations be for optimal heart health when it comes to maybe the type of exercise, the frequency of exercise, or intensity? Is there something that you typically recommend there for your
Right.
clients?
Probably every day, almost every patient, we talk about exercise and our goals and what the recommendations are. And the recommendations are based on national exercise guidelines. There's so much research and data, but the basic tenets involve to try to include at least 30 minutes of any kind of exercise 5 days a week that makes you slightly short of breath, but still able to carry on a conversation. And I emphasize to my patients that it's not about how high your heart rate gets or exactly what you're doing. It's not about, am I doing cardio or lifting? It's really just exercising to the point where you're at least slightly short of breath. If you're not getting at least slightly short of breath, then you're not getting the cardiovascular benefits. When Peter Attia describes exercise goals in his book, he talks a lot about zone 2 exercise. And that's essentially what it is, exercising to the point where you're slightly short of breath. And so some people like to use a heart rate monitor in order to help them identify when they get into zone 2. But for my patients, many of them are on heart rate control medicines for other reasons, whether it's arrhythmia or cardiovascular disease. So I don't like to use heart rate goals to identify what each person should do. And the National Exercise Guidelines also don't use heart rate goals. But it's just important to know, okay, you're getting into zone 2 and you're staying there. The higher zones would mean more aggressive exercise, and short bursts of more aggressive exercise like sprinting can help with weight loss or speed training, but not necessarily just for the cardiovascular benefits. So that's what I usually describe to my patients. But I like to add in the little extra also in case they have other goals in mind.
Yeah, thank you. That's really helpful, especially to know that that's not necessary. It's not necessary to have the fancy tools to just know, am I slightly out of breath, but can I carry on a conversation? I feel like it's very easy to check yourself on as we're working out.
Right. And then I always emphasize that over time, you'll find that the things that used to make you short of breath are no longer making you short of breath because you've built exercise tolerance and some endurance. And it's important to continue to change or modify your exercise program so that you're still getting slightly shorter breath, so that you can continue to grow.
Perfect. Thank you. Okay, so next we'll talk a little bit about sleep. So it's highlighted as just kind of overall for all of the four horsemen as a pillar of health. How does sleep, the quantity or the quality of sleep impact our cardiovascular function, or our risk for heart disease in general?
Sure. So sleep is one of, I think, the most important but likely overlooked elements of our day-to-day livelihood and life, but can be quite important, not just for longevity, but for cardiovascular health specifically. When I talk to my patients about sleep, it's important to get between 7 and 9 hours of sleep a night. And that's backed by lots of data and research, the amount of sleep. But then, many patients, especially as they get older, may tell me they have a tough time staying asleep or even getting to sleep. And that goes to some of the other pillars that Peter Attia talks about, emotional health or even cognitive decline or some other things. But from a cardiovascular standpoint, we talk about whether a patient might have obstructive sleep apnea and to get treatment for that. And that can help improve one's sleep. It can also help decrease their stroke risk, heart failure risk, risk of progression of coronary artery disease. So I like to talk about sleep apnea in that regards, even abnormal heart rhythms, certain arrhythmias like atrial fibrillation. But then to add in some elements sense of, how do we sleep better? And Peter Attia talks about, several items of sleep hygiene. For example, trying to avoid drinking alcohol at all, or especially within several hours before bedtime, trying to keep the room dark, trying to avoid blue light and electronics, avoiding exercise right before bed, ideally, because then their sleep will be better. And sometimes even the use of either saunas or meditation before bed can help for the sleep quality. You can use different metrics to assess your sleep quality. There's so much technology now between the apps on the Garmin watch or your Apple Watch or a Whoop wearable device. There are some devices that just sit at the bedside and you don't even have to wear to even measure your snoring. There's something called Snore Lab. It's an app, so there's so many different things a person can use, but certainly we do usually talk about sleep and the quality and quantity.
Thank you. Yeah, that's helpful to know, especially, things that maybe aren't wearable that are super easy to just keep by your bed and let it do its job. That's awesome. Perfect. Okay, another potential way to mitigate some of these issues in our health is managing our stress or managing our stress levels. And he covers this topic and then discusses it as a longevity factor. Could you explain for us what the cardiovascular impacts of chronic stress and maybe some advice on how to mitigate that?
Sure. I usually bring up stress with patients in several different kind of elements. Certainly, the less stress we have, the better sleep we might get. The more we exercise, the better we may be able to manage our stress and all the other elements that go with it. If we do have stress in our life because of either emotional or physical stress, then it can affect the cardiovascular system. I usually describe it in terms of the fight or flight system and hormonal response. So if you imagine stress that we encounter, we fight with the hormones that are associated with the flight or flight response. So our heart rate goes up, our blood pressure goes up, we start to shunt blood and to the vital organs and away from the periphery. But that may not be exactly what we want on a daily constant basis. That constant release of those hormones can, over time, lead to higher blood pressures consistently, or even lead to more coronary artery disease, atherogenic markers, and even elevated cholesterol, those kind of things. So to try to decrease or mitigate the amount of stress that you have. But sometimes it's unavoidable because of certain situations that may come up in someone's life. But just to know that there are some techniques. So whether, again, it's exercise, meditation, controlling blood pressure and heart rate, in even the temporary timeframes that we may encounter it as we go through grief in our life. But then to know, well, this may come and go. Sometimes patients ask me, if I start blood pressure medicine, does that mean I'm committed to it for the rest of my life? And this may be a 30-year-old asking me that question. And I have to let them know, certainly not. You're not committed to those medicines for the rest of your life. It's a temporary measure because of something that may be temporary in your life, but that we're trying to overcome. So it's certainly important because of those hormones that are activated when we undergo stress. But then to combat it is a lot harder. There's, psychiatrists, psychologists, a team of specialists that can help with some of the emotional stresses. And I think we're getting better as a society to actually utilize some of those resources.
Great, thank you. All right, so now we're going to talk about different medications that maybe he discussed, different metrics he suggested. So throughout the book, he makes a point that there are more tests available than what maybe many doctors are using, or maybe what's on your physical, like annual checkup, that kind of a thing. He also talks about the importance of metrics like cholesterol levels or inflammation markers. What biomarkers do you feel are the most important, or which ones do you generally track with your clients for cardiovascular health?
Sure. So I think for the most part, to just talk about cardiovascular screening and what primary prevention might include. So, for someone who has no known coronary artery disease or abnormal heart rhythms or any known problems, they just show up into my clinic because maybe they have a family history of premature coronary artery disease. Their dad had stents or cardiac surgery in his 50s. And so they're wondering, how can I avoid the same problems? So for screening purposes, I talk about just initially knowing your numbers. What are your blood pressure, your heart rate? Does your EKG look normal? What are your cholesterol numbers? And a basic set of labs. Is your thyroid function normal? Is your fasting blood sugar normal? That's pretty basic, and almost any doctor would do that. But not every patient would seek out that information at a younger age. They may wait until there's a problem before they look at those numbers. So the point is to look at those even at a younger age to know that all my numbers are at goal and I'm going to maintain those numbers at goal before there's a problem. And then when we talk about the specific cholesterol sort of subparticles, Peter Attia does describe looking at the LP(a) and the VLDL as a marker of inflammation, or which cholesterol medicines should we use. I really think that the statin class of medicines is probably the best out of all of the cholesterol medicines. Unfortunately, they're notorious for causing problems like muscle ache or pain or myopathy, but it's not actually as common as it is notorious. So it's worth initiating those medicines. The one that Peter Attia brings up is actually my favorite statin. It's rosuvastatin is the generic name, or Crestor. That's one of the most potent statins, but has the best side effect profile. There are other medicines that he describes, the PCSK9 inhibitors, for patients who may have familial hyperlipidemia. That's an inherited disorder of abnormal cholesterol numbers. And many patients who have that actually are not tolerant of the statins in my practice. So they end up needing those PCSK9 inhibitors. There's 3 on the market right now that are commonly used, and 2 are self-injection. Every 2 weeks you have to give yourself an injection, and 1 is every 6 months injection. So that's the newest one, but they're quite potent, and they can really bring down the LDL dramatically. So out of all of the cholesterol subparticles, the LDL is the most important. And I always tell my patients, I remember L for it's the one that you want low and it's the lousy cholesterol, as opposed to HDL, it's the one that you want high. It's the good cholesterol. And then, there's total cholesterol, which is the subparticles. We want everyone's, less than 200, but it depends on what's the HDL and what's the LDL. But to know what your LDL goals are, what your HDL goals are, and then your triglycerides. Triglycerides, even though they're part of the cholesterol profile, it's not truly just cholesterol. It's more a measure of how many carbohydrates or sugars are in your diet. It's much more diet driven. But there are medicines for triglycerides, and there are medicines for familial hypertriglyceridemia, an inherited form of abnormal triglyceride metabolism. So just to start with, those basics are important. And then there's much more. I'm sure we'll talk a little bit more about the other components of it, but that's usually where we start.
Great, thank you. Let's see. So he also talks about diabetes medication metformin for potential cardioprotective benefits. What is your view on using metformin, especially for people who do not have diabetes, just as a protective measure?
Right. I actually do recommend it to my patients frequently. Many patients are concerned about the possible side effects of metformin, and metformin is usually indicated for patients who have impaired fasting glucose or are pre-diabetic or diabetic. It's not usually indicated for the non-diabetics. So, but I have a couple patients on it who are not diabetics. They're actually elite athletes, and one is a physician who wanted to be on it for the other benefits that we'll talk about. But for patients who have impaired fasting glucose, prediabetes, or diabetes, I want them to be on metformin. There are cardiovascular benefits to being on metformin, in addition to metformin's ability to help with the blood sugar levels, fasting blood sugars, and then overall their hemoglobin A1C, which is an average of someone's blood sugar over 3 months. But metformin can also help with weight loss. It's pretty minimal, but still we want every patient to have every benefit and to know about all those benefits instead of just the risks of the medicine. And then when patients hesitate or ask me about the side effects, I let them know there are possible side effects. There's a short-acting metformin that has a few more side effects, usually GI, stomach gut related side effects like diarrhea, abdominal cramping. But there's an extended release form that avoids many of those side effects. There's still other side effects, so it's a case-by-case basis. Some patients who might be hesitant, I will discuss the research and data regarding metformin and its longevity benefits. The longevity comes from metformin extending the telomeres, which are particles in our body that have been known to be something like the fountain of youth, or when we talk about how do we extend life, many researchers think that some of the answers might be within the telomeres. And so I try to bring up that data just so that they know that elite athletes will take metformin for those benefits, not for the fact that they're a diabetic patient. So that often can help patients feel like there may be some untapped benefits that they don't yet know about, and may help them be more convinced that it could be beneficial.
Thank you. That's really exciting to know that you're, updated on all the research and you're willing to provide this for your clients if the situation is right for them. Perfect. All right. So the next topic is on the new emerging medicine. What is your perspective on new medicine coming out, specifically like weight loss drugs, and how that might affect cardiovascular health overall?
Right. I think in the area of cardiovascular medicine or prevention, primary prevention, probably the most exciting drug class are the weight loss drugs, the SGLT inhibitors, and the agents like Ozempic, Mounjaro, Zepbound. So those are the class of medicines. And there's much more research that is currently underway to find newer molecules that don't have the side effects that the current molecules have. Unfortunately, word is out that these agents can really help with dramatic weight loss. And so everyone's using it. Some of the diabetic patients are concerned because originally they were designed to help for treatment of diabetes, that we're running out of the medicine for the diabetic patients. But I think we just need to design more and make more in order to help the entire population have the benefits from the medicine. And that's kind of the most exciting field. I think probably 20 years from now, we'll realize that obesity is a chronic medical problem. Just like many years ago, we realized that depression is a chronic medical problem and may need chronic medical therapy for the, patient's entire life, not just something temporary. So that's how I kind of present it. Some patients may get a reset of their metabolic system with use of the medicine for a short period of time, and then may not require it lifelong. But just to let them know that it's still a lifelong kind of problem and that we need to continue to be aggressive about treatment. So that's the class of medicines that I think is really exciting. And lots of research is going to be underway. There's so many companies now that are not just doing the research, but trying to add on the psychological barriers that come with weight loss or weight gain, and trying to help patients overcome that kind of stressor also. So I think it's important to continue to pay attention to.
Yeah, that sounds exciting. Thank you.
Yep.
All right. Okay, so our last question for you. Which of, we've discussed a lot of potential tips, right? Sleep hygiene, or discuss potential drugs or potential tests to maybe ask your doctor for and know about. Where would you suggest that somebody start if they are kind of new to really getting to know their cardiovascular health? Where would you say would potentially be the best starting point?
I think it's really important for patients to educate themselves and to read a little bit on their own in order to come with a set of questions. But many patients do not even have a primary care provider. I think it's important to establish triage with a primary care provider to obtain the basic blood test, the blood pressure measurements, the preventative strategies that include screening for cancer and all the screening kind of to be initiated, because a cardiologist doesn't usually initiate the cancer screening or some of the cognitive testing that may be needed to be screened for at even earlier ages for some patients. So I think starting with a primary care provider would be helpful, and especially after some of your own research. For example, if you read Peter Attia's Outlive book and then have lots of questions, it'd be good to take notes and then present to a primary care provider to get some basic screening. And then the next really important layer to that is to actually listen to your primary care provider when they may recommend changes or interventions to your lifestyle or even medicines. I frequently will see patients where we'll have the entire discussion, we'll review everything, and then it's time to consider some changes or interventions, and then they become very hesitant. So sometimes I think only doing half the work is not enough. We really need to kind of follow through on it, and then continue to be persistent and vigilant about maintaining the numbers at goal, and to make sure that am I still at goal? What else can I do to get my numbers at goal? Things can change. Maybe, just like we hope that they improve whether it's your blood pressure, your weight, your cholesterol, you've got all the screening done, then it's also important to maintain that we're staying in range and that we continue to improve over time. Those are my general recommendations. And then if your primary care provider finds that you do need to see a specialist, it's important to just follow up on that, because the specialist may have lots of additional information that would be specific and targeted to you, as opposed to the general screening that you may have gotten with your primary care provider. So those are the main things I would encourage everyone to do, and to not be afraid of what you might find out. I think sometimes that fear keeps people from seeing a doctor because they don't want to know, but I think we can only all benefit from knowing more.
Thank you. That's incredibly helpful. I feel like that's an easy place to start, establishing that relationship with a primary care physician, and then seeing where that takes you and how you are doing right now.
Right.
Kind of like in financial planning, we have to figure out where you are before we can suggest anything, change anything, and then hopefully things get implemented and positive change comes out of that. Thank you so much for your time, Dr. Mozow Zuidema. I really appreciate it.
Thanks so much. Take care.
Thank you.